Allogeneic stem cell transplantation remains the only curative approach in many hematologic malignancies, especially myeloid diseases. And we have to admit these days that we are transplanting more and more patients who are in relapse refractory disease, who are in advanced stage. So we need to be pragmatic and realistic that the transplant by itself may not be sufficient. And we need to get ready to deliver post-transplant consolidation or maintenance approaches. So in another word, I think the philosophy of the allotransplant procedure is switching into a sort of a more comprehensive package where you try to optimize your disease control prior to transplant using all available drugs and options, including cellular therapies, but also after transplant, as soon as possible, to prevent disease recurrence, one should aim to deliver rapidly some form of maintenance therapy. And the best example about this, where we do have strong evidence now, is about the patient who are transplanted for FLT3 ITD AML. So in these patients, we do have very active drugs, FLT3 inhibitors, who can be safely delivered early after transplant and allow to further improve the disease control while waiting to the graft versus leukemia effect. And for instance, when it comes to sorafenib, we do have a randomized trial published in JCO in 2020. We do have another randomized trial published in Lancet Oncology, but I think other FLT3 inhibitors can be used. So the key message here is that whenever possible, I think in order to optimize the results of the allotransplant procedure, you need to deliver the optimal disease control prior to transplant, but also you need to deliver the optimal maintenance strategy after transplant. And putting all this together, this is where you can really allow the patient to enjoy the longest possible survival.